Good morning, everybody, and welcome to our Young IFSO session today. I'm really excited for the program that we have today, and we're going to be focusing on innovative education for young metabolic bariatric surgeons and teams. I'm really delighted to be chairing the session today. I'm Roxana Zachary. I'm the Young IFSO European Chapter representative, and with me we have Daniel Guerrero, who's the chair of the Young IFSO Communication Committee, and Moritz Felsenreich, who is the president of Young IFSO globally. We are really excited to have many of our active Young IFSO members here speaking for you today, but we will be kicking off the session with none other than Professor Bruno Dillemans, who needs no introduction, who is going to be talking to us about his fantastic program that he runs in Bruges, in Belgium. Thank you very much.
Thank you very much. Thank you very much, Roxana, and the two Daniels. Thank you very much. I'm far from being a young IFSO member, I have to be honest, you know. At my time when I was young, there was not something as young IFSO. When did it start, that young IFSO program? Is it 10 years or?
12 years ago.
12 years ago, yes. Already then I was not so young anymore, but okay, good. Let's go ahead. So you can see the Bruges Bariatric Fellowship model. How can high volume excel at the end in surgical education? You can see here my case mix disclosure. 2024, it's interesting to see that nowadays 37% of the patients that we operate are re-operations, either for weight gain, either for complications. And for the primary surgery, we still prefer in our institution, and by extension also in Belgium and the Netherlands and the Scandinavian countries, we still prefer a bit more the bypass than the sleeve gastrectomy. Although other surgical procedures are picking up, like you can see OEGB and Santoro, but not at the same, I would say, penetration as it is in other countries like in Brazil, etc. Now, I think to start with, it's interesting to mention first that I think bariatric surgery is an ideal research model to investigate the relationship between volume and between outcome. And why is that? Because we have plenty of potential candidates to go for a surgical procedure because the prevalence of the obesity disease is so high. And on the other hand, we have a relatively low variability in type of common primary procedure. 15 years ago, you had 3. Nowadays, you have probably 5, but it is contained. It's not a high number. And we have quite well could manage to make standardized techniques and care pathways, where for other type of surgery, it's not always so evident. But on the other hand, and that's important to mention, still and certainly, you know, when we started doing the Roux-en-Y bypass as an example, it's still a technical demanding operation. And we may not forget that sometimes, like you see here on the right side, we are dealing with high-risk populations with multiple comorbidities. And what is very important, certainly in public, is a lower acceptance of complications than for other domains of general surgery, like in oncologic surgery. And that you also see in the personal liability insurance that, like the UK surgeons have to pay to do bariatric surgery, is much higher than they would do general surgery. Now, a lot of relationship between hospital and surgeon volume has been investigated with mortality and also with morbidity, like for pancreatic surgery, as you can see here. And there is indeed that inverse relationship. So how higher is the volume, how lesser is the mortality or the complication. Also here, like for esophageal cancer surgery quite well, which have led in a lot of countries, like in our countries, that you just have selective hospitals who can provide those type of surgery, which is not still in Belgium if we look for bariatric surgery. And I think one of the first studies that really investigated the surgeon volume and the outcome in terms of complications is the study from the SOS. Everybody knows the Swedish obese subject study. And that was in 2014. And what you clearly can see, you know, how higher the volume of the surgeon will go, that the chance to have a complication is substantially less. And if you look to the secondary endpoints of that study, you also can see that the time that has been spent to do the gastric bypass, it is more selective for the bypass, is much less for those surgeons who have a higher volume than the surgeons who have a lower volume. And also you can see that the length of hospital stay is also much less in the higher volume surgeons. And then one of the best studies, I think that most of you have already seen that study from John Birkmeyer from the state of Michigan. It was a fantastic study in the New England Journal of Medicine published, where he not only looked to the volume of the individual surgeon, but also on the surgical skills of the surgery, which is very difficult to measure, but he had a fantastic plan. He asked to the 20 quite well-known bariatric surgeons of the state of Michigan to hand over a single representative video of a gastric bypass. And this video has then been ranked on different domains of technical skills like dexterity, tissue handling, etc. Have been rated by 10 peer surgeons. And what you can see that those ratings have then been correlated with the risk-adjusted complication rates that have been nicely registered during 6 years before. So it was encompassing more than 10,000 patients. And it was amazed to see that what a relationship you can see, that those surgeons who had the highest strength on surgical skills have seen substantially less complications than the other group of surgeons. And if you look then to the secondary endpoints as well, the risk to have reoperation, readmission, and emergency department visit was much less in those higher ranked surgical skilled surgeons. So very interesting that indeed you see it's not only the volume but also the individual skills of the surgeon, which I think is a very important parameter to keep your morbidity and complications as low as possible. Here you can see a bit my start of my journey towards becoming a high volume center from the start. We started with some open procedures at the end of the 90s, but at the early 2002, 2003, we were most of the time doing pure restrictive procedures, which was the VBG, vertical banded gastroplasty. The laparoscopic version was the McLean version. We did quite a lot. You can see 2004, we did around 500 of those McLeans. And then we changed a bit to the band, but at the end, for all known reasons, we went more to the gastric bypass, which is still, as I said, our preferred surgical technique as a primary procedure. And what was very important that from the start doing the laparoscopic bypass, I did my first laparoscopic bypass in 2003, so that was 10 years later than Alan Whitgrove described the first laparoscopic bypass. It was at that time retrocolic, retrogastric. You know, I was really willing to keep my complication rate as low as possible. So I was really keeping an eye on my data. And what I've seen to keep the complication as low as possible, that there's just one way to work. Certainly because we are dealing with high volume, it's a standardization of the procedures. For myself, for my team of surgical trainees, fellows, and nursery staff, for the whole care pathway, and at the end also for the patient, which is the most important. And for that standardization, we have split the Roux-en-Y gastric bypass in all different steps and phases. And for all of those phases, like the initiation, the gastric pouch creation, the making of the gastrojejunectomy, important steps, we have not only split it, but we also designed a specific role for every participant. Me as the surgeon in the middle, assistant on the left side, assistant on the right side, but also for the scrub nurse, they have designed tasks to perform. And by gaining much more experience, we could rationalize each single laparoscopic maneuver, leaving behind all unnecessary, time-consuming, and potential harmful acts. And just for an example, the close of the GG anastomosis, which I think takes, 4 or 5 minutes, but we really not only analyzed it, but we put on paper every step we're doing during that procedure. And not only even putting on paper, we try to synchronize as well, so that the X of my left assistant, right assistant, is really according to what I do myself. So if you look at the way we closed that for case 1, case 2, case 4, case 400, is by way of speaking nearly the same, regardless a bit of the BMI of the patient, the BMI is 6 or whatever, or if we are dealing with more complicated cases. One of the most important steps is still, I think, making the gastrojejunectomy, and I started, like a lot of surgeons, with the linear cartridge, but then, because we were doing more and more revision surgeries where sometimes the gastric pouch is very small, that I decided to go for the circular stable gastrojejunectomy. We started with a 21, but we quickly went to a 25. And what is one of the biggest advantages, I think, not only for the vascularity, but also the reproducibility of making that anastomosis with the circular device is the highest. Certainly, sometimes we have 3 theaters running. I have to lean on the fact that my assistant is doing that exactly the same way as he or she has been trained. On that part, although it's a bit more expensive, we all know that, but I still prefer the circular stable gastrojejunectomy. And surely when we are evolving more to revisional surgery, it is really, I think, a benefit to make the anastomosis at that manner. Either also, you can do that manually, you all know that, but if you do that manually, then the outcome becomes more dependent on the surgical skills of the surgeon, and I try to exclude that as much as possible. So there we tackle we're going to visualize the ligament of Treitz. We're going to lift up the root limb, the elementary limb. We're going to bring it in through the left trocar, and then we have to perforate the small bowel nicely anti-mesenteric. So there are small tricks to do that, because we're not willing to encompass, to put the vascularity of the small bowel into the anastomosis. And then we're going to do the formal resection of the candy cane, as you can see here. So that is the standardized way of doing that anastomosis, which is still the critical phase of the gastric bypass, making a proper gastric jejunostomy. I was very lucky to have a fantastic anesthesiologist in my team. He's now retired, Jan-Paul Mulier. Probably some of you know him very well, because he's not only very dedicated, he was also a very good researcher. And I can see here on the right side, we were looking to have the best position of the patient on the table, gaining much more access in putting CO2 in. And what he investigated is that indeed the flat position, as we were doing that in the past, is not the best, you know. So now we are using the beach chair position with flexion of the hips around 30 degrees, and this is relaxing with the rectus muscle. So we could show in his study, you know, that sometimes we can gain 1 liter of intra-abdominal volume to just placing the patient on that side. So we worked nicely together in trying to optimize the outcome together with the anesthesiologist. And then the way we standardized our procedures have been nicely compared, the analysis of that, with other teams, that is already, I think, 15 years ago, with other teams throughout the world. The team from Kelvin Higa, from Fresno, everybody knows Kelvin, Alan Whitgrove. And on all details that we do, the gastric bypass, have been compared. And what you can see here, this is just one of the analyses, the trocar mapping. The black dot is the way we do that. You can see that a lot of surgeons are placing the trocars very low, which I think is not so good to perform, I think. And at the end of the analysis, what you can see that the time that has been spent to create your pouch and make your gastric jejunostomy in our team was substantially less than in the other teams, 27 minutes versus 42 minutes, and also making the GG anastomosis was shorter in our experience. And at the end of the procedure, in the completion of the procedure, you can see that we're spending more time to check for leaks and to check for bleedings. And then we published our results of the first 2,600 patients in obesity surgery, of the standardization, the fully stapling of our operation, 2009. And what you can see in terms of the crude figures, the hard results, that in terms of mortality, we just had one mortality. There was a patient, very obese from the Netherlands, who died 4 days after surgical procedure at home from a cardiac arrest. And I think that those good figures were at least partly attributed to the fact that we have a very low anastomotic leak, 0.19%. And if you compare with the papers that have been published at that time, you know, this was our mortality in comparison with the other papers, unicentric, multicentric, as well as you can see the leak rate, 0.90%, was highly favorable towards the results that have been published in other institutions. But still, we always can do better. In our publication, we have seen that the results of the bleeding were still relatively high, 3.4%, needing sometimes to do an early reoperation on early stage. And so on that part, we together with the anesthesiologist were coming together in trying to implement fine refinements to get our bleeding risk down. So we upgraded the stapling devices, we dissected better the blood vessels around the bursting suture. We were elevating systematically the blood pressure at the end of the procedure, which still a lot of institutions are not doing that. We do that systematically, you all know that, to 120, 130 millimeters of mercury, putting more hemostatic clips and sutures. This is a nice publication where we're using smaller staple height to get the interluminal bleeding down. That's a kind of nice publication on that. And you can see, you know, here, if you just systematically increase the blood pressure at the end of the operation, you can see that you could have a distinct bleeding here, but otherwise it's going to be not seen. So it's a pity not do that relatively simple act, but you have to have a committed anesthesiologist in doing that for sure. And then to look to the impact of those small refinements, we split our first 10,000 bypasses in 5 cohorts. according to the time frame that have been operated. And what you can see is that, according to experience, the surgical complications got down from 3.6% in the first cohort to 0.8% in the last cohort of 2,000 patients. And the most important impact was indeed on the bleeding complication. It got down from 3.05%, got down to 0.6%, just to have that better way of dealing with bleeding and also for sure a leak. And the surgical revisions, that's certainly important. The first 30 days got down from 1.6%, statistically highly significant, got down to 0.2%. Just the last 2,000 patients comparing with the first 2,000 patients. And then we expanded our experience of the standardization of the primary procedure to the conversions of the band to a bypass with, I think, the most elaborated experience throughout the world. You can see a paper of 3-4 years ago, I think, on obesity surgery on 1,295 patients. And what you can see here, as you're going to briefly, we did not have any leak at the gastrojejunostomy or the GG anastomosis. We just had one bowel perforation with a clamp, with bile coming out. A day after surgery was it already a bit, as it was a leak, but anyway, we could manage that clearly quite well. And what is interesting also during the experience that we developed, that the risk, by way of speaking, to have the necessary to do it in 2 stages, band removal, and then 3 or 6 months later, do the second procedure, has faded away. Only for migrated bands, we never do that in one step. But you can see that the figures of 2020, nearly all of those patients with a band and converted to a bypass, we could manage to do that in 1 stage, which I think is certainly favorable for the patient. Same experience in converting the VBG to the gastric bypass, also I think a very elaborated experience. You can see 329 patients, and we had 1 leak. Also those figures I think are quite favorable to the results that have been reported. The second highest number is from Michel Suter, but that was a multicentric study. Our center was unicentric. So I would conclude in regarding the gastric bypass that the complete surgical standardization and surely also the high surgical volume and the high quality of anesthesia, very important, enabled us to have a very low 30-day mortality and morbidity. And so the procedure has become a real safe procedure, which I think is important, and very important, easily reproducible and very effective for training. And so on the gastric bypass, you can see here, that is the way we train our surgical fellows and our trainees. You can see here now in the middle, one of my trainees who had already the experience of 20 primary bypasses, and she is then being carefully looked after by a surgical trainer who have more than 70 primary bypasses. It's Nick de Wever here. And then we have a lot of foreign fellows, as well, who are joining us. And they can join from the left side to the right side to increase their skills. And depending on the time they have spent of us, they can do more, but we have to always look what are the individual skills of the surgeon. And this is still a variable that you never know when we have fellows coming over. Now, for the sleeve gastrectomy, that's very important. We're all over the world. I see that the sleeve gastrectomies are done by the resident or the trainee, and the chief does the bypass. In our institution, it's the opposite. My residents may do the bypass, but always have to be there for a sleeve, because it's a much more unforgiving procedure. There are much more technical details in the sleeve, where you have to be very careful. The angle of vis, you have to stay away 1.5 centimeters, and then the incisura angularis, how many mistakes have been done there, because the surgeon were coming too close. And also to prevent having a coiled sleeve, you have to be really very nicely making your staple line nicely away, and that the distance from the lesser curvature and your staple line is quite well on the same distance. So those are technical details on the part that I still have to be there. Now, Shansi Agrawal, who is the chief editor of the most important textbook of our job, he was 1 year with us. He wrote a nice article on obesity surgery regarding this fellowship training, and he concluded that a 1-year fellowship supervised by a bariatric expert is ideal, as this provides training to achieve not only baseline competency but also proficiency. 1 year is long, I understand, but then at the end, when Sanchi was trained with us, he could do everything on the same manner as we were doing with even the low risk of morbidity and mortality. Now, the last 10 years, we have to say, I'm going to end by that, we have swifted a bit from the primary procedures more to the revisional ones, so we have a lot of courses and fellowships that join us. Revisional bariatric and metabolic surgery for either complications, either for weight gain, sometimes also the combination. And I would just end by saying those messages for the younger surgeons. And we always train our surgical trainees, not only in technical skill, but also in the thinking process, So what I would just end by saying that try to do the right thing, in your patients if we're dealing with complications, if we're dealing with weight gain. And on that part, discuss and prepare your case properly. In case of weight gain, you have to have that multidisciplinary consultation for sure, with ethical consideration, and you always have to balance the estimated gain in weight loss, comorbidity control, versus the risk to have serious complications. And what is very important, in case of complications, listen carefully to the complaints of the patient, evaluate the X-rays yourself. In so many centers, they always look to the protocol. I never look to the protocol for an upper GI. I look myself, and think logic. Just to give you an example, this is a case during the corona that was admitted on Facebook, and the surgeon was asking everybody, specialists, what is happening in that patient. The patient got a sleeve gastrectomy 2 weeks before and was admitted as an emergency in his center. And what you can see here, there's a huge dilation of the esophagus, and that's important what you can see here. And this is also on CT, you can see something there. Anyway, that's interesting. If you can see what the comment was given by all specialists, I'm not blaming that, but you see, try to think logic. Some surgeon was opting doing esophageal manometry. Esophageal manometry, we see things. CT volumetry first. Another surgeon was thinking achalasia. Achalasia, 2 weeks after the surgical procedure, that is the most acute onset of achalasia I've ever seen in my life, okay? Then, otherwise, we're going to do balloon dilation in ascending pressures. Okay, good. I will start with placing a stent, and then we go for a bypass. What is that all, Then, we're going to do the new magic tool. We're going to do high-resolution manometry. Please, what is that all? So, that partially covered stent. Now, what is the problem in that particular case? Please, I've not seen that patient, but I had contact with the surgeon afterwards. What you can see, huge dilation, and what you can see, that's here, the gastroesophageal junction. And what you can see here, there's a small part here of the sleeve that could herniate it inside the chest, and you can see here the chest. So what was the case, and sometimes it could happen, with a chorioplasty, not chorioplasty, a part of the sleeve got herniated and by this incarcerated inside the chest. So this patient had to be operated, has been operated as well. So just common sense is not so common, really try to think logic, it's I think important. Second thing, right thing to do, think as an upper GI surgeon more than a pure bariatric surgeon. You always have to think about not only doing a good anatomical correction, but you have to focus what's going to be the functional outcome afterwards. How will the food passage evolve postoperatively? Will GERD disappear or aggravate? And do not ignore long-term side effects or complications. Just an example, those are all patients that had to operate for bile reflux after an OHGB, bile reflux. All surgeons were doing a nice anastomosis, but what you can see, all those gastric pouches have been far too short. So you cannot blame Rutledge or Carbajo, etc., that they didn't describe the technique very well. You have to make a very long pouch according to the description of the literature. And then, last, the thing to mention, have advanced laparoscopic surgical skills, know yourself and your limits, always try to perform a careful dissection, and prefer always to use sharp scissors, certainly to prevent iatrogenic thermal injuries if you use other devices. Can I always make a safe staple line transsectional anastomosis? Embrace the classic stapling recommendation and always be sure that in the worst case scenario, you can manage to make a safe manual anastomosis. If you cannot do that properly, don't start doing bariatric surgery. Just here you can see gastrojudicial sleeve, a procedure that we do frequently for weight gain. Always be careful how the anastomoses have been made. Just to show you very briefly, if the anastomoses have been made with a linear device, you always have to be careful when you do the gastrojudicial sleeve that you're not going to have a triangle. You can see here a triangle at the end of the operation of a lesser vascularized tissue. And then you could think it's a hematoma. No, that's not the site of a hematoma. This is potential less vascularized part. You can do ICG, etc. If you see that, patient will be doing good day 1, probably also day 2, and when we got home, you're going to have a perforation. So in those cases, you have to take your responsibility and you have to make a new anastomosis. In 1 minute, I finished. So we're going to make a new anastomosis in those cases, and it's going to be safe. So always, try to look very carefully and act accordingly. And last slide that I will show and those are a bit hidden secrets of becoming a high-volume center after all those years, and though all could be summarized in X that you probably better not do. And one of the things is I've never been too innovative in my life, you know. So do not jump on every new procedure or approach as is appearing, gastric plication, ICG. I'm not going to say anything wrong about it. But, you know, we may not forget, everybody's on social media nowadays, that poor results get much more attention than good ones. Secondly, I've never been interested in having supranormal results. I'm not interested to have an excess weight of 130%, you know. Why not, you know? The better is the enemy of the worst. And last but not least, do not perform extremely difficult or risky operations. Bariatric surgery, although we do a very important job, is still not oncologic surgery, where you just have one chance. If a patient has pancreatic cancer, you have to have a Whipple, and you have to do a portal vein resection. This is the only chance of the patient. Then you have to do risky operation. Not for bariatric surgery, so because it's not acute life-saving. And there's a bit, you know, the international fellows that have visited me, you can see a bit high number throughout the world, and I'm always very pleased to welcome everybody. Thank you very much. Thank you. That's here in Malaga, you can see. I've not been in that street yet.
Thank you so much, and it's brilliant to hear straight from the source, because I think so many of us and so many at this conference have either been trained directly by you or have been trained by someone who has done your fellowship and been trained by you.
Thank you.
Some really important learning points there. While the audience has
Elena was there as well.
If you have any
Elena,
questions, could you go to the microphone there? While we're waiting, I just wanted to ask, for early career surgeons, you mentioned how important it is to look at your own outcomes and keep a log of those and analyze them. What do you recommend are the key metrics? Because otherwise you could keep a lot of data. It could take a lot of time to do in a busy young surgeon. What are the key things that you think are important?
I think the time spent of your procedure and then the complication rate. That's it. I think that's the most important factors, you know. I mean, it's not allowed anymore, although I'm not going to talk about the robotics, which is taking longer, and you have the learning curve, etc. But, you know, you have to speeden up your learning curve in time spent, I think. Honestly said, we are very tough on that part. We have 5 bypass, 1 room, 5 bypass. Then the surgeon takes 2 hours and a half. I mean, then he has to go back, you know, understand? So, but besides that, the complication rate for sure, complication rate. But on that part, we always do a good leak test. We always have a formal instruction. We never do an APGI after surgical procedure. But my guys know when the leak test is showing something a bit odd, you know, they have to call me, you know, because then we have to put some stitches. So on that part, Thank you.
Thank you, doctor, for this excellent presentation. I just want to ask you for the standardization, for the first step of gastric bypass, and we are dissecting the lesser sac and the gastric wall. And sometimes if there is a posterior adhesions, it is so hard to make that first part. Because of that, lately I started to open some that avascular area.
Yeah. You go from the greater
there,
curvature.
And there is a window. Is this a good step?
I think in case of dense adhesion or the patient's pancreatitis in the past, you can do so. But are you leaving the gastroepiploic artery intact then? Because I'm not willing to severe this one. Because this one of the
side.
On the right side,
In the middle side, yes, medium side.
Yeah, but you are mentioning that you go from lateral, probably, you know, and to tackle then to go medial. Is that what you suggest?
Yes, from the liver side.
The greater curvature side?
From the liver side.
Yeah,
from the liver side, there is a Parks flaccida.
Yeah,
you are opening and you preserve the lesser side.
Yeah, but okay, but the Parks flaccida is much more easier to enter. But anyway, that is the way that they did the bypass long time ago. You have much more risk to severe the dorsal vagal nerve, which you cannot do. If you have to do an undo later on, you know, the patient going to have problems with the pylorus. No, you have to stay. What I advise always to stay very close to the gastric wall. You have to do that fine dissection. Even if there are some adhesions, okay, you have to tackle that individually.
Maybe okay, I mean that we don't touch vagus. We just go behind the just see the window.
But that's the proper way then. Okay, but that's the way you can do so, and you leave then the vascular branch and the dorsal vagal nerve, and then okay, that's also. But normally we just stay by the lesser curve. That's a technical detail. I think in all cases we could manage to do so, and in the worst case, you have a traumatization of the gastric wall on the back side. You go a bit more cranially and you close that. In the rare cases, we had some trainers having those problems, but it's still manageable. Okay.
One more question. We did a Young IFSO survey where we saw that about 40 to 45% of the residents they are not allowed to really do any steps of bariatric surgery within the residency time. How is it in your center? Is it
So that is what we mentioned as well. We have a nice colleague from Oman as well. Let's say, you know, we have a program where, depending on the surgical skills of the surgeon, and we know we have a lot of fellows coming over, and the CV, honestly said, is looking fantastic always, you know, fantastic, etc. papers. But this is still not saying anything about the individual surgical skills. So that's still a subjective thing. I can see how is the dexterity left-handed, right-handed of the surgeon, and I let them do a bit, you know, although I'm not mentioned it, otherwise it's too much stress. And then already can see, you know, what is the potential that they can do X themselves, you know. And there's a big variable on that amount, I have to say that. But if they're more skillful, they can gradually increase, and they start from the left side, then they go from the right side, we have to do a bit more, and then they first make the GG anastomosis. If that's going to be properly done, then they make the gastrojejunectomy. It's all in steps.
But all within the residency, right?
I'm sorry?
Yeah, but all within their residency time.
Yeah, for sure. Yeah.
Last question, Panagiotis.
Thank you very much for this wonderful presentation. Just a fast question about robotics. How would you transpose your program, what you're doing exactly as training, into the robotic training? Would you do this? Would you perform the same steps? Would you change something?
I think that we have now also, my colleague is doing now robotics with the Da Vinci and is doing that properly as well, only the time consuming, the docking in, docking out time. I'm a bit too old for that shit, but okay, that's a personal thing to do. But the way they do that is nearly exactly the same on that part. I've seen the guys, it's very nice and making more hands-on anastomosis, etc. No, they do, but the steps are identically the same. So we don't start with the GG anastomosis, we always start with, because still you have some surgeons starting distally, we start proximally. The way to dissect is the lesser curvature, that we reticulate a bit the vertical staple line. It's all the same on that part. Yeah. We have a console. We have a proctor also was coming. A proctor, we have two consoles. That's right. Yeah, to correct it. Yeah.
Thank you very much.
Thank you.
Our next speaker is Daniel Guerro. Just, I think 1 year ago, you take over the lead of the bariatric unit in Zurich. He's also the chair of the communication committee of Young IFSO, and he will speak about novel surgical education and data-driven simulation.
Thank you, Moritz, for this kind introduction. Dear audience, dear friends, yeah, that's correct. So I'm running the bariatric unit in the University Hospital Zurich under the lead of a professor who is responsible for both oncologic upper GI reflux and bariatric when needed. Thank you for the opportunity for letting me give an update on novel, maybe innovative surgical education and data-driven simulation. I would like to start also with a case mix like Professor Dillemans did. We are a reference center. More than half of our activity is revisional, and the other half is split between sleeve and bypass, Roux-en-Y gastric bypass. Equitably, we don't do one anastomosis in Zurich. So regarding training, I found this quote from Aristoteles that we are what we repeatedly do. Excellence is not an act, but a habit. When we look back in time, like in the Middle Age, as shown by Rembrandt, that surgical anatomy was taught by a maestro wearing a strange hat, and a lot of people admiring and learning from him. In this Flemish-speaking part of the world, this hasn't changed over the centuries. There's still a maestro in the middle wearing a strange hat with a lot of people admiring him. But now we have some other tools that I would like to show in this talk, how we can do it differently. I think it's important during the training to have some smart objectives, specific, measurable, attainable, relevant, and timely, always dependent on the context. For bariatric surgery, there's data to support different levels of expertise, which can be classified as competency, proficiency, or even mastery. And depending which publication you read, you need at least 150 Ks to become proficient in bypass, and you can still improve your skills to become master during your 151st and 500 Ks. For sleeve gastrectomy, apparently you need a bit less Ks to become proficient. Already after 50 or 100 cases, you can consider yourself as proficient and can still increase your skills until 200, where it seems to plateau. What supports the knowledge transfer is a well-established curriculum. previous experiments with other laparoscopic skills and high volume centers. Last year, during our educational session, we discussed what is an optimal pathway to become bariatric surgeon. It takes about 10 years. It has different items: residency, a bit of research, fellowship, and then the joy of surgery. So the question is, how can we integrate simulation into all this? Well, you can put it at any time of this timeline. You can start during the residency, you can simulate during research, and even when you're a grown-up surgeon, if you want to learn a new robot or a new procedure, it's worthwhile to go back to the simulator. The concept of simulation is very well developed and even obligatory in the flight industry, and I think we have some things to learn from them. They're also trying to improve the way the pilots do the simulation, and I just want to show you some conceptual changes in the aviation simulation training pathway. So the traditional way was that the trainee goes into the simulator, and then an instructor tells him what to do, then the instructor gives real-time feedback, and then the future pilot is simulating independently. So the more efficient way to do that the person arrives to the training already after having looked some videos at home, and when they arrive, they try to replicate the expert's action. They interact with the trainer for corrections and feedback. And once the simulation session is done, they can go home, bring home the videos of their simulation, compare it to the benchmark, and try to improve by critically analyzing what they did. And I think in surgery, we have the possibility to do this efficiently. There are countless excellent resources online for videos from experts, IRCAD, SAGES, IFSO, you name it. I think it's a bit more difficult to have a good mentor. In my experience, what worked out really well is the Royal College of Surgeons clinical fellowship, where I had brilliant mentors and always good feedback. And then it's a never-ending story to analyze your errors, as also suggested by Professor Dillemans. What's also interesting that simulation may start even earlier, before even one can consider a surgical career. It has been shown in different studies that those who have exposure to video games perform better in hand-eye coordination. You can measure it in different ways: overall score, time of completion, instrument collisions, forces used, etc. So how is simulation implemented in Europe at the moment? What I've seen that in Poland, they found that in the gynecologic residency, the use of video reality simulation-based laparoscopic training is increasing skill acquisition, structural factors, and they're trying to implement it in the national curriculum. In Portugal, actually one of a young IFSO collaborator, Mr. Gonçalves, developed a model which can be used for open surgery training, laparoscopic training, and also robotic training by providing some kind of synthetic organs which even bleed if needed to simulate real environment. And this will be implemented in the curriculum for residents in Portugal. In Netherlands, they found that the standard pelvic trainer is too easy, so they have now a model for vaginal nodes simulation with a single trocar access, because they demonstrated that these skills need to be developed more in details before going to the real patient. In the UK, they're using pelvic simulators, but what I found interesting in England, that they emphasize the objective way of scoring trainers, so they can compare their outcomes between them. They use the Global Operative Assessment of Laparoscopic Skills Score. This measures the symmetry of knotting, the slippage, and the tension, and it can provide metrics which can be addressed by the participants. And now we have all these robots in our hospitals which are used in clinical practice, but the beauty of them that they can be used in the evening or on the weekend also for training, while they are not exploited for clinical purpose. And in new studies, it has been shown that the physiologic parameters of the trainee are better, less tachycardia, less signs of stress when they are simulating on a robot, contrary to a laparoscopic simulation. I don't know whether it's good or bad, but this is what they found. In Switzerland, they're trying to take this whole data-driven simulation to a different level. They realize that it's very costly, actually. So a couple of years ago, the government launched a big collaboration, including tech companies, universities, these engineering schools, and they created a kind of a transformative way of surgical education project. with iterative cycles of AI-driven analysis, testing, learning platforms. They closed, I think, the cycle this year or last year, and they will publish the updates. What we already know, that it brought even clinical breakthroughs. In an orthopedic clinic in Zurich at the University Hospital Balgris, they've been using hologram instruments to train screw placements in surgery, and the technique is so good that they could do a world premiere, and they did a holographically navigated operation on the spine in a real patient later on with virtual reality glasses. Another spin-off of this public-private collaboration was a company which is using cadavers that they scan and use it for 3D modeling of the anatomy to improve the medical education of students. What do we see in the world of bariatric surgery? There are a lot of articles flourishing from all over the world. There is a so-called video-based coaching in bariatric surgery, which has been shown to improve outcomes in robot. If you look at you use metrics, time to achieve a certain task, and number of errors, collisions, and tension. In Italy, there is a rising interest on the augmented reality training. They just published a survey on the state of this use in the country. There are also validated models of ex vivo organs for Roux-en-Y gastric bypass. There are also unpublished models. I've just been recently to the London Training Center of the Da Vinci robotic company, and they have their own non-published, excellent Roux-en-Y gastric bypass porcine model for robotic surgery training. So the opportunities are there, and I would encourage all of you to use it. In a recent study which compared the quality of training using extended reality with non-extended reality models, you can see on the forest plots, every study and the overall sum of the studies is favoring the training achieved with augmented reality. But there is something else we can use as a so-called biohacking strategies, also advertised in pilot training. So one is related to sleep hygiene. It is recommended to take care of our sleeping, sleep enough hours, avoid the disruption of the circadian rhythm, check for temperature, light, everything. Think about what you eat before training or before operating, avoid heavy meals. And also use some mindset tools, so-called chair flying. Imagine the operation before it happens, and improve your skills of situational awareness. And to close this talk, I would like to also show that there are situations which are beyond training, which you cannot really train on any model. This is a picture taken a couple of weeks ago of our entire upper GI bariatric team, all surgeons together at 1:30 in the morning. And because we had to take care of esophageal perforation, I was officially on call, so I had to be there. I called my boss, who came to help, and also my other colleague came, who is planning to take over the esophageal cancer portfolio, and he came in his free time to take advantage of this rare case and take ownership and get exposure. And the enthusiasm and the mood was, and the camaraderie was so positive in the OR that the anesthesiologist initiated that he takes a picture of us, because he never sees us together in the same operating room. But this joy break off when at 8 o'clock we had to crack on with our outpatient clinic. So thank you very much for your attention. I'm very happy to show my colleagues the support I receive from them is priceless, and I hope to see most of you in Zurich, where our department is co-organizing the European Foregut Society meeting, which will have a dedicated session on the reflux hiatal hernia repair in patients before, after, or during bariatric surgery. Thank you so much for your attention.
Thank you very much, Daniel, for this excellent presentation. I think you should have my future perspectives in training talk tomorrow. It's really impressive what you found out. So, are there any questions from the audience? So you presented many different AI tools here. If a clinic could only implement one of them to the practice, what do you think is the most important one?
I would start with the basics. I think what I see in our residents, that they incrementally improve their skills when they have access to basic laparoscopic suturing stuff. I would have this as a baseline, and then I would add on until the money allows it. What I mentioned, I think It's important that once the hospital acquires a robot, even for other surgeries, gynecologic, urologic, whatever, the robot is there physically. So you have to make contact with the representative of this company to have your own account. So you go there in your free time in the evening or even during working hours, depending which country you work, which kind of agreements you can do. I remember that Professor Dilleman told me that in Belgium now the residents, like in coal miners, they have to badge when they arrive in the hospital, go out. We don't have this yet, so it's, you have to. Okay. So yeah, it should be in harmony with the culture you're living in. But I think the basic things like suturing is the most important. This is a transferable skill. Like residents are not bariatric surgeons. They have to do appendectomies. They have to do all types of procedures. So it's a transferable skills. And this is like reading or prescribing paracetamol to be comfortable to not tying and suturing. Yeah, that would be my guess. But if you have access to glasses, go for it.
Thank you, Daniel. It's exciting that there's so many simulation tools, so many virtual reality things that we can do, and people can learn their skills not on the patients. Many of us have learned by doing it hands-on on patients. Do you think a time will come where you will no longer be allowed to train on patients until you have reached a certain level on simulation? Is that right, or should we still be doing hands-on within the clinical practice from day one?
If we go back to the example to the aviation industry, it would be unimaginable that somebody flies a plane without simulating before. And on the same plane, the people who are passengers in the plane are the people who we operate on. So same society, same people, similar rules should apply, maybe, but I don't know. I'm not a politician, I cannot make any decision. But maybe even a time will come where humans won't be allowed to operate on humans, everything will be automatized.
Are there already quotation measures or that you say, now only the simulation, now you're good enough to go to the next phase? Is it really also put on paper already, because otherwise it still remains a bit subjective, what we are doing is also subjective.
Yeah,
but
yeah.
Are there accurate measures, that say, this surgeon has passed this level, you understand?
Yeah, that's what I tried to mention just briefly from the UK. They are trying to standardize everything. This global operative assessment of laparoscopic skills is one way to try to compare people or compare the evolution of the same person over time. I don't know, maybe Roxana knows more about this because it's more prevalent in the UK. I've never used this tool myself, just read about it.
No, I mean, I think it's still in the research phase as well.
You don't see what I see, sorry.
With Metabolic now as touch surgery, which we are using now, and this is really, really good. Only the thing is that it's just now still the time spent for these type of procedures. All the rest is going to be with AI, but it's not completing perfectly well yet. But anyway, there are now tools, but it's still not
yes, just a short comment. There are metrics that will be available soon in the next, probably next year or in 2 years. There are, for example, Intuitive are doing metrics for robotics, or academies like OC Academy in Belgium. They will start doing metrics for bariatrics. So we will have this for robotics. There will be metrics, hopefully, but for laparoscopic surgery, for sure, it has to pass from experts who train the younger surgeons.
Thank you very much, Daniel. So next speaker is Roxana Zacchieri. She did a wonderful work within the last 4 years for IFSO European chapter. And we'll speak about modern culture and handling of adverse events and taking morbidity, mortality conferences to another level.
Thank you so much, thank you. So I'm going to talk about something a little bit different, but it's still very, very relevant in terms of training. So what we're doing in terms of training, what we're doing in terms of our outcomes for bariatric surgery is becoming ever more visible and ever more scrutinized with registries and data. But I think our culture of how we discuss complications, of how we learn from complications, hasn't necessarily kept up pace. So we're going to talk a little bit about what needs to be done within that. How many of you in this room remember your first complication? Your first major, yeah. And how did you feel? Alex, how did you feel? Very bad. Yeah. So, I mean, I remember mine. And I remember it was a sleeve gastrectomy. Technically, we did all the right things. We raised the blood pressure at the end. We gave tranexamic acid routinely at the beginning of the operation. We made sure that hemostasis was perfect at the end. And then what happens that night? The patient has a bleed, unexpectedly. And that initial impact, the first response was, what did I do wrong? You felt emotional, felt guilt, felt upset, felt panicked what to do about this patient. Have I caused harm? But then I was surprised that there's always a secondary response, and probably sometimes a bit sooner. And this is the societal pressure, the culture of not just the patient, but also thinking about, well, what will the department think? What will my colleagues perceive it? How will this be measured in terms of what impact will it have on my or the unit's outcomes? And then what will it impact how we consent patients for the surgery and what patients think of the unit? And all of those thoughts come in a very short space of time that then an individual in their learning phase then has to deal with and be supported by. So it's really interesting about how we discuss that at the moment. And in modern surgery, when outcomes are increasingly transparent, they're publicly reported, sometimes at individual surgeon level in the UK, complications can feel professionally exposing as well as emotionally devastating. And then we look at the culture of our morbidity mortality meetings. They have always aimed to improve. They've been around for over 100 years. But how many of you, I mean, I've personally seen this picture, the first picture here. The environment is has been traditionally focused on what was the error, what was the mistake, who was responsible, and often focused more on the personal structure, a blame rather than a culture of, well, let's say, what are the conditions that led to this mistake? How has the system led to this, including what Daniel was talking about, optimizing the environment, your human factors, all of those things, and a lot that we can learn from the aviation industry about it. And ultimately, we know from an immense amount of evidence that culture leads to patient harm. If people are working in that culture, if you're training in that culture, people are less likely to speak up, they're less likely to share their experiences, especially the negative ones. They're less likely to want to discuss openly and honestly, and therefore things don't necessarily get learnt from. You end up with a rinse and repeat model of cases are discussed and then they're retrospectively documented, put away, and they happen again years down the line, either in the same unit or in another unit. So it's important to think about the culture within which these M&M meetings happen. And in the UK, it's been widely recognised that these toxic cultures within a department that aren't necessarily just focused on complications, but in terms of how surgeons work together, the professionalism, how the multidisciplinary team are treated, and also the impact on patient care, can lead to those toxic environments that lead to scandals in patient care. And the government then said, about 10 years ago, that a whole-scale culture change is needed from blame to learning, so much so that the Royal College of Surgeons created guidance documents on how to manage disruptive behaviours in surgery, but this should have been written, and actually the whole document is based on managing disruptive behaviours by surgeons. So it is important that we do focus on this, and I don't think the culture has necessarily changed enough in that time. M&Ms have been around, as I said, for over 100 years, but a lot of documentation from over 2 decades ago have shown that this culture of learning from error is not necessarily there. Traditionally, the traditional structure of M&Ms focus on retrospective discussion, they often focus on the individual blame, and the educational value is therefore lost. And if action measures are put in place, there is often not a system whereby they are then re-evaluated and the recommendations are re-audited for that loop closure later on to see, well, has this led to quality improvement and has this improved team performance? And importantly, that psychological safety of being able to discuss things openly and not hide mistakes for fear of it impacting your career and your reputation was absent. So why does this matter to us specifically in metabolic bariatric surgery? Well, we're hearing a lot at this conference about technological advances, innovation, and all of that brings, difficulties within the increased risk, especially in our patient population who are now operating on sicker patients who are undergoing liver transplants with heart failure, kidney transplant patients, rather than the more straightforward ones. So we really have to think, well, all those decades of learning curves that, for example, Professor Dillemans was talked about, and people needing that time, we're going to have to be making those progresses in a far shorter space of time, and clearly simulation is going to help with that. But alongside that, we have increased scrutiny of our outcomes, we have increased transparency in the public, and patients are quite rightfully more aware of needing to evaluate their surgeons and competition and look at your outcomes. And we can't deny that bariatric surgery is litigious. Our indemnity, our insurance as bariatric surgeons is inevitably higher than most general surgeons because of that perceived risk. So our morbidity and mortality cultures do need to evolve at the same pace. So I was thinking about how we can improve the structure as well as the culture and what's needed. And I think that word structure is key. So many, rather than individual case discussions, histories discuss what happened, senior people in the room say what could have done better, and then the case is closed. We need to have a formal structure about how M&Ms are discussed. That, firstly, I think of it in 5 pillars. You need the psychological safety as a baseline. Then you have a structured case analysis with certain proformas, and I'll show you one model that has been used successfully in the literature. And it needs multidisciplinary participation. We work in a multidisciplinary team. You need those perspectives of the anaesthetist. You need it from the dietitians, the physician, the nurses. You need to have all of those inputs and reviews about what went wrong. Why did that ever occur? And also then it really needs to be focused on action. What is the positive learning point that can be gained from this? And then what is the positive step that we can take forward to make sure this never happens again? And that accountability, also setting the targets, but like Daniel said, having something that's measurable, and then having a period for re-evaluation set at that time point in the M&M meeting, and then revision of that later on down the line to see, has it improved? So how many of you know Amy Edmondson? I love this lady. She's fantastic. I think you should read everything that she has written. She has worked a lot on the concept of psychological safety, and specifically in high-performance teams. And I think it's really important, if you read it, you will get she doesn't necessarily focus on healthcare in most of her literature, but you can transfer a lot of the things that she said to your daily practice and see the key figures that she talks about in terms of, you'll recognize them in your departments, and measures that you can very easily do. And one of the things is this psychological safety. It doesn't mean being soft. It doesn't mean not critiquing people. It doesn't mean being constructive or avoiding difficult conversations. You do need to do those, but we do need to be able to speak up without fear and work better together in order to keep patients safe. And it's about having those tools within a team structure that are very formalized, objective, unemotional, critically, and unaccusatory to be able to do that. And what is the human cost ultimately? There are complications, and we talk about the impact on patients, but as I mentioned at the beginning, there is that second victim. And Albert Wu described this in 2000. I don't know if many of you have heard of that. He described a case that he was involved in, and how as surgeons, as clinicians, we can be the second victim in this. It can follow you, depending on the case. It can often follow you around for many years. It can then impact how you operate. We all know surgeons who have done one technique, had a bleed, and then have said, forever now my technique has changed immediately because of one experience, rightly or wrongly. So whether you realize it or not, it can follow you around. And then we also, with our young IFSO, did a study on specifically many of us metabolic bariatric surgeons. It impacts burnout. It's one of the key things that leads to pressure within your job, emotional pressure, not just the physical aspects of the job. And many of us have reported that you do feel that pressure to perform, and that if bad things happen or if patients perceive you differently, it does impact your daily life and your family life and your physical well-being. And one of the key things is we talk a lot about person-first language, about communications with patients, but I think it is so important that we think about communication with each other. And this is something I think typically in our hierarchical structures, especially in surgery, with the old style stereotypes and environments, things can be quite bluntly said, and the culture has changed. And I think it's really important that we focus on how we speak to our juniors, how we speak to our peers, and how we speak to our seniors, and everyone within the wider multidisciplinary team. Your words matter, and not just that, the tone of your words matter. So it's important that we should challenge ideas, we should be raising concerns and talking about mistakes, but aggression is not a marker of excellence. Humiliation is definitely not a teaching strategy. There's so much evidence to say it puts people off surgery. It makes sure that they never get back into the operating theatre again, or they're fearful, and therefore their hands-on skills don't progress as well. And being civil is not being weak. Culture is important. It's not separate to patient safety. It is safety. So the future, technology is really important. There are so many ways that we can bring this in, whether it's discussing simulation models, using AI and video-based case discussion. There are numerous ways, and companies are using that in order to be able to bring that into our discussions. AI can help detect patterns to help us look at complications, and then it's important to have even anonymized cross-institutional. We have lots of national cases discussions, and Bariatric is one of them that Professor Dillemans does, but other ones within your regions perhaps where you discuss complex cases, and important in making sure that you do audits of this to make sure that there's equity and no bias, and making sure that young trainees are involved in those discussions and come to the meetings. I remember lots of trainees who also always avoid this meeting, think, oh, it's not important, I want to go to theatre. No, it is really important that trainees come and listen to the M&M meetings, get involved in the discussions, and learn about that aspect of the career. So it should be multidisciplinary, psychologically safe, data-driven, and then always focused on improvement. And this study by Mitchell used one tool, the SBAR format. I don't know if you've heard about communication, where you talk about situation, background, assessment, and then review and literature and recommendations. And they found that using a qualitative assessment, there was a 44% increase in what was deemed the quality of those discussions. So finally, just say complications don't define you as a surgeon or your unit, but how you respond to them does. And it's important that we move from blame to learning, take away the hierarchy, and focus on action. Please follow us all on European Chapter on all our social media channels and Young IFSO ones. And then don't forget we have our Young IFSO get-together this evening at 7:15. So please come and we can discuss everything about what you've learned today. Thank you.
Great, thank you very much. Are there any questions? Yeah, Eleanor.
Is there any unit in UK have a real program of second victims in your hospital or in any hospital in UK? For example, in Spain, we're now in my hospital, in several hospitals in Spain, we're working on a second victim program, but we're still working on it.
Mm-hmm.
But I read some papers that went from UK.
Yeah.
So I want to know if it's really is a reality in your country, if you have that real second victim programs.
Yeah, so the Royal College of Surgeons of England is actually now developing a program, and they have had the pilot where it's supporting surgeons. So they have on a national basis brought in senior surgeons and multidisciplinary team members to have a program whereby your unit can say can sign up, I think they pay £2,000 and sign up to be supported for 2 years, to have surgeons and anyone from the MDT referred to this meeting. It's also a counselling program whereby you can discuss what happened, you can discuss the personal impact. It's not focused on the clinical case at all, it's focused on how you as a clinician then can be more mindful of the impact on you and how when you've had a significant case. So a colleague of mine had a death from an emergency in general surgery. He thought he was fine with it, was okay, but a colleague recommended, why don't you go along to this just to see? And he went to that session at the Royal College, and they talked about the second victim phenomenon. They had a period of one-to-one interviews and group sessions, and he now to this date sends everybody to it and says that he learned so much about himself and what he wasn't even mindful of the impact on him from that case and how he's practicing. So I think it is really important, and yes, fantastic if Spain is having a program. We should do more locally as well as the national ones.
Yeah, maybe just a comment. I saw that in different hospitals, the M&M conferences, how they are doing that, is very different. Yeah, so from very proper case presentation with videos where you may really see the mistake that has been done and reflecting yourself, until in another hospital I saw that they just once a month, and they called it also M&M conference, reported we had 3 bleedings, we had 2 leakage, and that was it. Like. Are there guidelines on that, how to really fit with how they should look like?
Yeah, well, a lot of the literature for the past that I've seen over 20 years has talked about you should have this structure. One of them followed the S-bar format. But yes, to really go into detail and have that case discussion, have the learning points, the action points, the review. I don't know of any specific ones for metabolic bariatric surgery. Perhaps that's something that we can work on as young IFSO. But there are also key things in terms of like benchmarks of things that can then be used as comparators, and also regional and team discussions with seniors, and even meetings. I think that so many of the sessions we have, I think that's where a lot of the learning can come. But in terms of specific one body that says this is what you should do, no.
I will also have a quick question. So I've read an interesting concept on the next level of morbidity mortality meetings, I think in an house of surgery from Michigan, where they argued that we should not only discuss the cases that went wrong, but we should also pick cases which went well beyond expectations, and they call this the resilience engineering. Despite all the red flags, you managed to navigate the case safely through. Is there any pick up on this concept in the UK, or what do you think about that?
I mean, I think that's a brilliant idea. Like, you should also discuss the near misses. So in the UK, there is a national reporting system for near misses. So there are a set number of never events in the UK, like putting a nasogastric tube down the trachea. Rather than that, there are a set list of them. And if things have not necessarily happened, but were near misses, like the tube happened and the patient wasn't fed, it was realized early, they have to be nationally reported and discussed within the patient safety framework. But a lot of those are very, very significant things. And maybe we've all had cases where, you know, a patient has done well, maybe there was something, or potentially you were worried about something and then a preventative measure was done. So yeah, absolutely, that should be included. I don't know of any formal structures otherwise.
Thank you very much.
Thank you.
All right, thank you, Roxana. So I have the pleasure to introduce Thibaut Coste. Please come on stage. He will talk us about novelties in self-management, how to work smarter, not harder. Well, yesterday he did not really demonstrate this skill. I spent 11 hours with Thibaut examining candidates for the UEMS exams, and it was hard work, I can say. So please apologize, Thibaut. He lost his voice in this battle.
Yes, a little bit. It's recovering. So
Thibaut, please.
Thank you very much. So thank you very much, Young IFSO crew, for this great opportunity, and thanks Sonia, who unfortunately was not able to come, and so she gave her talk, which was not so easy at the beginning, so I have to think a little bit about what I was talking about. So I decided to talk about my personal experience. So, early in my career, I believe something very simple. If I work harder than everyone else, I will become a great surgeon. I think that was the message that they gave me during my residency. But so at the beginning, I say yes to everything. Most cases, more night shifts, more responsibility, and for a while it worked. I improved my skills. I started to work in a private clinic just after my 2 years of consultant surgeon. And I'm focusing on surgery only. But with the time, I feel something strange. Just because my surgical practice was a little bit stagnating, I start feeling a little bit stuck in my daily practice, in my routine. And so that's when I understood something that changed everything. I asked me a question: am I capable of doing the same thing every day for the next 35 years of my career? And the answer was no. So just think about the myths. We were all trained in the hospital to work hard, to learn more, to stay longer at the hospital, to do one more case, one more night shift, like I say, and to make sacrifice at the beginning of our career. But in this model, there is a problem. The reality, if they are not dedicated to an academic career to become a professor of surgery, many young surgeons, with the time, they feel stuck or overwhelmed, because hard work without great strategy can lead you to a stagnation. It was what happens in my case. And no one showed us how to build a smart career out of an academic career. And so this is for me the turning point. So if you want to work smarter, you need a structure in order to become a better version of yourself. Okay? So, first thing, build strong foundation. So, before we talk about working smarter, we need to be very clear about something. Like I said before, hard work is essential at the beginning. There is no shortcut. And at the beginning of your career, your job is simple, but it's not easy because you have to master the basics. You need to be safe, you need to be consistent, and you need to be confident. This is something that we try to offer at the Young IFSO. We can help you with that, with the Become Bariatric and Metabolic Surgeon course. I organized in February the third edition in Montpellier. Sonia will organize the fourth edition in April and June, and Omeli will have a fifth edition this year in Bucharest. So great success for this course. I think you can learn many basic skills, and it could really help you to improve very fast your learning curve. Second, you need to build a strong network, because at some point your growth is no longer depend only on how hard you work, but it's on who you connect with. You need to find mentors who guide you. You need to find peers who challenge you. I think yesterday was a good example for that. You need to find colleagues who can open doors that you didn't even know they existed. You need to find mentors. You need to be gathered by peers and try to be involved in international collaboration, because those kind of international collaboration, they will shape your opportunities. So get involved in scientific societies in your country, but internationally also, because at some point you need to go further. You need to get involved, because scientific society, or for me, platforms where things happen, where you can find collaboration and where the future leaders are identified. So get involved in those in your country, but also abroad, in order to bring a very strong network, in order to be in a spotlight and create huge opportunity. It will help you to build a strong reputation. Just in my example, I studied in the French Metabolic Surgery Society, the SOFCOM, in May 2023. Then in 2024, thanks to that, I was elected president of the Club SOFCOGEN, which is like the Young IFSO in France. I organized my first national meetings. It was in my town, more than 100 attendees, so it was great success. And during the same period, I started to involve myself with the Young IFSO group, and I organized the Become Bariatric Metabolic Surgeon in February this year. And at the same time, I joined the UMS committee, and I participated to the first examination yesterday. You also need to publish, because at some point, something has to change, because you move from learning to contributing. If you don't share your work, your impact will stay limited to your own operating room, your own hospital. And when you start sharing through papers or presentations, something will happen. You become visible, you will connect with others, and you will get more opportunities. But you also need to develop your soft skills. And this is something that you will not learn in your hospitals. And you have to do the job by yourself. So develop your soft skills like communication. We'll show you why it's important for me. Because with patient and public speaking, because your technical skills make you competent for your peers, but the patient don't see that. Okay? The patient don't choose the best surgeon. The patient choose the surgeon they trust. And this is very important, because you don't need to be the best surgeon to have more patients to your clinic or to your hospital. The patient, they see how you communicate. They try to find a connection and a trust with you. You are a medical doctor. Okay? They give their life to you, so the first thing they are searching is the trust. So as good communication can massively improve your recruitment and your reputation, and I will show you that. So in my case, 2022, like I said, my recruitment was stagnating. I live in south of France. It's a very beautiful geographical area. There's many surgeons who want to come in the south of France, and it's very competitive. And so in 2023, I decided to engage on social media with mainly medical information content about metabolic bariatric surgery and weight loss. And this is what happened. I increased my number of surgical cases per year by 50% in 2024 and 50% in 2025. I'm not saying only 1%, 2%, 5%, say 50%. And you have to know that in France, surgical activity decreased by 30% during those years. So I'm the opposite. It's decreasing in France and increasing my activity. And just look at the data that you can find on social media. So in just 60 days, I'm capable to reach out about 1 million person in France and in Europe, just publishing medical content about metabolic bariatric surgery and weight loss. Okay, so it gives you a very, very good visibility, and the patient with this connection, they're gonna come to see you to your at the consultation with the feeling they know you. I think you all follow influencer on Instagram and everything, and you know a little bit of their life, and it gives a connection, and you think that they share their life with you, and you like that. The patient with the medical doctor or the surgeon is the same thing. So you need also to be strategic with your time and your energy, because don't forget that time is limited and your energy is even more. I understood that very quickly when my first child born, because when you get kids, you think differently. So choose high impact activities, avoid dispersions. Don't think that you can do everything or every kind of surgery. This when you start surgery in your clinic, you want to do everything. It's not the good solution. Focus and try to build a strong ecosystem around your main activity. And above all, very strong advice, don't forget your family and your hobbies, because they are the foundation of your stability, and you can walk because you're stable in your daily life. You know, I was 15 days ago, I was on the top of the Mont Blanc, so I'm not only doing congresses, I'm also doing what I love, mountaineering, running, and everything. So practical roadmap for the young surgeon. So phase one, master the basics, so focus on fundamentals and find mentors, very important. You need to find a guide. Phase two, you build your ecosystem, so you start publishing, you build your network, and you attend conferences like today. And phase three, finally, you design your impacts, your leadership roles, you develop your expertise niche, and you can scale impact. And so just to conclude, I would like to invite all of you for the next Become Bariatric Metabolic Surgeon in Naples in June, so it's pretty soon. I think there is some spots still available, but be quick, because if not, you will lose this opportunity. And finally, if you have 5 to 10 minutes during very boring presentation, just take this survey, because we are conducting with some friends survey about the social media use among MBS, and it's endorsed by IFSO, so please take 5-10 minutes to answer, because we need many more answers to globally understand how it's work worldwide. Thank you very much.
Thank you very much,
So I
Stephen.
try to do something a little bit inspirational, I hope.
Everyone's inspired now. Do we have any questions from the audience? No. In terms of finding mentors, often it is luck in terms of residency of where people work and the departments that they work in. How would you advise a very junior person starting out to approach sometimes people that seem quite scary, quite intimidating? How would you approach them how do you advise them to approach people to become the mentor?
Most easy thing is to find the mentors where you work at when you start your residency. If you engage on MBS, you will find a professor of surgery of MBS, and if it fits, it will be your first mentor, like your surgical daddy. Mm-hmm. But sometimes, with personality it doesn't fit. So my advice is to travel. You need to go abroad. So maybe the fellowship, it's very good advice. You need to, when I was in France, I worked in Montpellier. I had so David Necker, first mentor. Then I went to Lille. Went François Patou, second mentors. And then when I started endoscopy, I went to Strasbourg, and so I met Silvana Peretta. So you need to travel. I think the fellowship, it's for me the best way to find a good mentor. Yeah.
Thibaut, so your social media presence is really top. So do you do it alone, or do you have a team around that helps you with that?
No, I do it all by myself. Last year I took some advice from a company, just in order to, redesign a little bit the layout of my different social medias. But I do all my content all by myself. But when you are used to do that, it's very fast. It's the same message that we give every day in conferences, in consultations. So the speech is the same. So just have to put it on the video. It's not very difficult. And you have now a lot of AI tools that can help you. And so you just have to do one video clip per week. It's enough. Maybe do 1 or 2 stories. It's not hard work, and it takes less than 1 hour per week. It's nothing.
And what percentage of patients are reaching you through social media?
I don't have the data. I never try to get this data, but I would say at least 50% now for in case of obesity. It at least 50%.
Oh, great.
Yeah, just a comment on that. For bariatric surgery, it's true that patients go to social media. It's not the same, for example, because I'm doing also oncologic surgery, it's not the same for oncologic surgery. They don't go to social media. But for bariatric surgery, they go a lot in social media. So it's a good tool. And regarding the making of the videos and all that, it's true that I don't know if it takes only 1 hour per week, maybe more for some of us, but there are companies in Europe and worldwide that can do that. For example, the cost of this for 1 video per week in Greece, where I'm practicing actually, is something like 300 euros per month. You can find people doing this in a really good way. So it's something you can try for bariatric surgery. Yeah.
Very important thing. And for example, in oncology, the patient is referred to the surgeon by an oncologist or another specialist or the general practitioners. But for bariatric surgery, the patient chooses the surgeon. Okay, this is completely different. It's like in aesthetic surgery. Okay, we are in the same. The patient chooses the surgeon. It's not the general practitioner who will send the patient to a surgeon. We will try, maybe we'll give some names, but at the end, the patient will go on Instagram, on Google. You need to get the stars and the quotation on Google. You need everything. You need the website. You need.
You said you doubled your patients last year.
50%? No, not well. In 2 years. Yeah.
Oh, in 2 years.
Yeah.
Okay. They are seeking for surgery or for
Yeah, it was only.
because you also have.
No, I was just only taking about cases of surgery and in the endoscopy. So it was for mainly ESG and surgery. I didn't put the gastric balloon because in France it has been removed of the market. But when I was doing a gastric balloon, when I start social media, it gets very, 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 very fast. And now I have many patients. They come for the drugs, yeah, because I do some content about GLP-1. So they see me and they want to. They come to me just to get the prescription. But they come. I say it's like a cloud. The patient, he comes for drugs. You prescribe the drugs. You put it on the surgical cloud, and 3 years later, you download from your cloud, and you get to surgery, ESG or another thing. So.
Thank you. I think in the interest of time, I think we should go to our final
There's just a
talk.
study recently published that shows that there's something like 15 to 20% of your patients who come just for GLP-1s, then they come to you for surgery. There was a team that published this recently. So it's about 15%. These patients will come to you for surgery after.
Yeah, if you give a solution to the patient, he will come back later.
So thank you, Thibaut, for this nice talk. I expect our LinkedIn Young IFSO site to increase followers by 50% by the end of this session. And I'm very happy to introduce our global Young IFSO secretary, who is doing a home run. Elena Ruiz from Spain will finish this session by giving some updates on robotic training.
Hi, everybody. I'm going to split the talk in two parts. First we're going to talk about the availability for young surgeons, and then the second part is the latest technological updates. So to start, have nothing to disclose. And we know that robotic bariatric surgery is increasingly available for young surgeons, though all those institutional investment and training programs and challenges. But what are the factors that are influencing availability for young surgeons? The training programs, the institutional adoption, a specialty focus, and the cost and economics. So if we have a look for some papers, for example, what is the situation in United Kingdom and Republic of Ireland? About 70% of trainees would value greater access to robotic surgery training. 73% believe that robotic surgery was important for future, and also more or less the same percent believe it should be incorporated into formal surgical training. So they also perceive disadvantages as this is expensive, and the current impact of consultant robotic learning curves on training, that they are also in their learning curves. And in this paper, if we compare the situation between UK and Ireland with USA, and the graphic is very, very clear that in USA, they have much higher use of robotic surgery in the United States of America compared to United Kingdom and Ireland for trainees. In this paper is UK surgical trainees. There is a Delphi consensus, and they decide that there is a robust consensus amongst UK surgical trainees on that they are supported, the trainees strongly supported the integration of robotic training into surgical curricula in all the fields, yes, not only upper GI or bariatric, but also in HPV and orthopedics and the other surgical specialties. So what robotic programs do we have available for young surgeons? So we have the course curriculum. The course curriculum is not a real curriculum, but it's a tool, it's a scale that assesses key physiomotor skills in robotic surgeons. And what a course does is an objective assessment and a skill differentiation between beginner, intermediate, and advanced residents. So we have tools to measure and to metric our skills and the development of our skills in robotic training. The key components of the course assessment is the standardized scale, a video review, and a reliable scoring by blended video raters and in-person faculty evaluations. So how course is used in robotic surgery training? By integration into training programs, tracking progress, and identifying skill gaps. And for example, in this paper, they show how course, we can see in the graphic that using course program, you can develop your skills, and as you know, the trainee pass every year of the training period, the progress is much better. We have also the ROCKS program, and it's similar to the course program. That program was implemented in the daily routine of German university hospitals starting in 2020. And it was based on a basic training through assistant at the operation table during robotic assistant operation, and also a basic console training. So this program is a strong training tool to meet the specific needs of young surgeons and evaluate their learning success of robotic procedural training. Thus, many in many occasions we can find that this is not safe for the patient, but does this entail any difference in patients' outcomes? Okay, we can see in this paper that they analyze this data, and using this program can be safely integrated into clinical practice without compromising the safety or the oncologic quality of surgery done by trainees. We have also other programs for robotic surgery training, as for example, the START. This is just developed in the United States and is just for 45 fellows in 1 year course. So it's for very, very few young surgeons, but in the United States they are lucky because they have this program, but it's just dedicated for US trainees. As Dr. Gero mentioned before, the silicon models are very useful, and they published this paper telling us how useful was the silicon models to train in robotic surgery. And all of the trainees consider that there was a very, very good anatomical models, better than virtual reality, and also is a very low cost way to train and to develop your skills. Also, we have the programs from TRUX is the Robotic Global Surgical Society, and we have plenty of programs with incredible mentors, with very, very high skilled mentors in robotic surgery. And we can apply, you can apply for that and ask for them in United States, in Europe, in Latin America, and also in Asia. So yes, you have to get in contact with them and try to go there and learn from them. And for sure, our that we saw before, our next course, Become a Metabolic Bariatric Surgeon in June, then we have also a part for robotic surgery training. So there are many programs and organizations dedicated to advancing this field and fostering collaboration between experienced robotic surgeons and the young surgeons. So, but the majority are in North America and Europe. There are huge differences between USA and the rest of the world. So we need the requirement of boosting and spreading robotic educational programs worldwide is key. So when we ask, for example, to young surgeons what they think when you say robotics surgery, they think in futile, but always also they think in precision, but also inexpensive. They have a very, very clear idea that nowadays robotic surgery is still, and robotic training is still very, very expensive. And the second part is about the technique and the technological developments and updates that we have in robotic surgery. So this started in the 80s with the Puma. Puma was the first robot that was used in surgery, not in bariatric surgery, but in surgery. Our present then, during all in the 90s, Da Vinci came up to our lives, and now is the present. But with robotic surgery, we can enhance visualization. We know that we have a 3D high definition visualization, so it's a better depth perception and detail. We also increase precision and control. Robotic arms can articulate in ways that human hands cannot in 7 movements. Training and simulation. We have sophisticated training programs and simulators before performing actual procedures that is very, very safe for our patients. And telesurgery, because we can now operate it in a remote mode, and this is incredible. So the first one was Da Vinci, and this was the first Da Vinci. But nowadays we have developed more and more platforms for robotic surgery. We have a huge amount. The third generation of Da Vinci was older, now it's older, but it's still used in many places. Then come the fourth generation with the X and the XI. The X is a more cost-effective version of the XI and have a different bedside car design, but that makes the procedures focus just in a single area. And the Da Vinci SP was the single port of Da Vinci, that is a single 2.5 centimeter incision, and that is perfect for narrow access surgeries like urology or transoral procedures. More about technological updates. We have Da Vinci 5, okay, this is the last one, and this was released in 24-25. The key point of the 5 platform of Da Vinci is that the 4 sensory technology, the haptic feedback, this is the key point and the most important feature of this Da Vinci 5. The force feedback is the first of its kind technology. This instrument sensors are able to generate post-operative objective performance measurements on tissue. This incredible, and early in their surgeons, we are all early in their learning curve. Model fear errors because they have the perception of how strong they tie the tissues and the pressure that we are doing. But it's not only Da Vinci in the world. Okay, we have also Medtronic from El Hugo from Medtronic. It's a modular system with independent arm designed. The CMR surgical Versus also, because it's very small and modular and portable design. Also, we have the Asian brands like Hinotori. Medicaroid Hinotori is a Japanese developed forearm bed system, and the Mir company Roboy also as well. And this is from South Korea, but is also very developed in and spread in Russia, Kazakhstan, Uzbekistan, and that part of the world. We have a Sensus surgical Senhance. It's an haptic feedback, 3 millimeter instruments, so very, very, very small instruments. We have Badera Medical. Badera is a German engineer for urological procedures. We have the Chinese technology with Tomai, that is a very, very strong competition for Da Vinci system. The virtual incision Mira, this is a miniature single pore robot and direct insertion into the abdominal cavity. No docking required. This is very important, and is now approved by the FDA for bowel resection procedures. The distal motion Dexter is another platform, combine robotic precision with manual laparoscopy, because it's an hybrid, it's a mix between laparoscopic and robotic, and you can change from robotic to laparoscopy if it's necessary in less than 20 seconds. So this rate advanced, and it's more cost-effective plug and play solution. We have also another Chinese, the Can Duo, is for urological procedures. It's well known by the name of SageBot, and it's a 5G remote surgery, permit 5G remote surgery, and is assistant in the Asian market, is a very, very strong competitor for Da Vinci. So we have a look just in the map how the different brands are used worldwide. We can see that Da Vinci and Versus and Hugo Ras is about North America and Europe, and in Asia Pacific also Hinotori, Tomai, or Kandu are very, very used nowadays, and in Latin America, Da Vinci, Hugo Ras, and Versus. So what's next in robotics for us? Yes, there are coming new and more platforms. The Moon Surgical Maestro is an assistant robot design, and you can also try it and practice a little bit, because we have it in this Congress. The Essential Robotics is a combines between 2D and 3D imaging, but it's for bone and orthopedic surgery.
The Cineflex is from Iran. It's a flexible robotic system currently in clinical trials. And these platforms are generally aimed for better integration into existing operating rooms and lower operational costs compared with all the well-known Da Vinci system. So we have also updated on the last technological updates in AI and machine learning into robotic system, enhance decision-making, improving surgical outcomes, and providing real-time feedback to surgeons. So this synergy enhance precision, reduce human error, and personalize patient care through every stage of the surgical process. In this paper, we can see the different level of development in robotic world until when we're looking for to have that full autonomy of level 5 of robotics. So for me, the key phases of the AI and the integration of the machine learning is the preoperative planning for analysis 2D images that create 3D anatomical models, intraoperative guidance in the computer vision, decision support, task automation, and in post-operative analytics because AI evaluates by video feeds and kinematic data. So in this paper show that how impact on outcomes using AI, the metric and the reported improvement. Okay, you can see that they experience a 25 reduction of operative time, decrease in a 30% the intraoperative complications, 40% improve the surgical precision, and 15% faster the patient recovery time. So the future points are that fully autonomous systems for a specific repetitive steps, the expansion of telerobotic surgery, remote procedures, and AI continues to evolve, and the future of robotic surgery is supposed to become even more remarkable in paving the way for a new era of personalized, precise, and patient-centered surgical care. So for me, the future of surgery is not about replacing surgeons, but is augmenting our abilities. So thank you so much, and please don't forget that we have in September, from 1st to 4th September this year in Toronto, our World Congress of IFSO. Thank you so much.